So I think that Frankie's having some technical difficulties with her internet this evening. So what I'm hoping is that everybody who's watching can hear me and see the slides as well. If there's any problems with that, then please do put something in the chat so we know and we can sort out any sound issues. So my name's Deborah Kirkham, and I'm a consultant in sexual health and HIV, or to give it its official name, Genitourinary Medicine. And I've been asked to have to give a talk today about the career, about the good, the bad, and the ugly, how you can get into it, what the application entails, what training entails, and why you'd want to join me in this fantastic specialty. So the first thing that I was asked to talk about was a week in the life. And it's tricky because if you speak to any gum registrar or any gum consultant, it's going to be a different week for them all. And that's the beauty of the specialty, that it lends itself to a portfolio career and to doing different things. But I'll go through the basics. I'll talk a little bit about what I do and what other opportunities there are. So what most people will do as a significant part of their week is a gum clinic or sexual health clinic. And in this regard, it's anything from diagnosing, treating, explaining infections, so chlamydia, gonorrhea, herpes, warts, trichomonas, mycoplasma genitalium. You might be dealing with skin issues, so the cross-section that we've got on the right-hand side, that's lichen sclerosis. So we deal with any genital dermatoses as well, and some sexual health clinics will have specialist clinics because as we examine so many genitals, patients often come to us first and think that they've got an infection, but actually it's not infectious at all. It's a skin condition like lichen simplex or lichen planus, lichen sclerosis, like in the picture. We see non-sexually transmitted infections that are still infections but are not passed on via sex. So things like thrush, you can see in the top right, that's a microscopy of spores and hyphae. So the spores are little round blobs and the hyphae are the long, thin lines that you can see, and that's a sign that somebody's got candidal infection if they've got symptoms as well. Some gum doctors will do contraception, and it depends on the clinic you work in. So in our clinic, we're not fully integrated in that if you come to the sexual health clinic, then we won't, for example, put an implant in you or do an injection, but I would do a contraception consultation. If it's something like the pill that I can prescribe there and then, I would do that. Otherwise, I would refer over to our contraception side, who are co-located, but we just have separate clinics. There is a move towards integration, so it's more common that if you see a woman, for example, that you'll be doing everything from their sexual health screen to their contraception, but it depends on the clinic that you work in. And then I've put up at the top, so safeguarding. So again, depending on where you work will be different. So I work in Croydon. It's a very young borough, unfortunately quite a lot of deprivation. So we see a lot of safeguarding of children, but also of adults as well. So we need to be on high alert, really, as all our colleagues do across the country. But we do specific questionnaires called Spotting the Signs, which help us to gather information from the individuals to ascertain whether or not there may be any safeguarding concerns and what we can do to help them. And then in the middle, we do preventative work as well. So this is PrEP, pre-exposure prophylaxis. So this was a relatively new intervention, started a few years ago to reduce people's risk of getting HIV. So it's a tablet that you take either every day or around the time that you have sex, which reduces by 86% the risk of you acquiring HIV from somebody that's got it. And actually, if you looked at the 14% of people who got HIV, their drug levels were either absent or very low, so they weren't taking their tablets. So it's just the gum clinic on its own. We see so many different things. Then a big proportion of what I do 1.5 HIV clinics a week, which compared to gum, I do 3 gum clinics, but actually my HIV clinic generates a lot more work outside of the clinic than my gum clinics do. So from the HIV clinics, there's all sorts of different things that we address. So the first thing is looking after people with HIV and making sure that their HIV is well controlled, and that means using HIV medications, antiretrovirals, and choosing the correct ones for the individual. So we're incredibly lucky that, 30, 40 years into the epidemic, we now have wonderful drugs with very few side effects that we can use to keep people's HIV well controlled, and so that they can't pass it on to other people. But it's still important that we tailor the medications to individuals. So there isn't a one size fits all. So it might be that people want fewer tablets, or it might be that they don't want to have to eat with their meds, or it may be that they've got comorbidities that mean we have to be careful because some of the medications can affect your kidneys or your heart, for example. So we choose our medications that way. And we deal with all the additional issues that come with a diagnosis of HIV. And it is different to being diagnosed with cancer or diabetes, because it comes with an incredible stigma, which is a leftover really from the early days when it was a death sentence, and stigmatized as well by the mode of transmission, which is usually sex, and in the UK usually sex between men. So there's all these layers of stigma which have accumulated and which we're fighting hard to get rid of, but unfortunately it's still stigmatized even within healthcare, let alone within the general population. So we support patients to deal with that, and a lot of our patients on our advocates, this is nationally, and advocate for people living with HIV. Just put on here as well some of the other things that we deal with. So I mentioned that there are comorbidities that we have to think about, and it's not just comorbidities that people might come with already, but HIV causes comorbidities. So even in somebody with well-controlled HIV, they are at higher risk of, for example, renal issues and cardiovascular disease. So we need to keep an eye on these things, and some larger clinics will have joint clinics set up with the renal physicians or with the hepatologists, for example. You can see at the top that's an MRI scan of HIV encephalopathy. So if people have had HIV for a while, it can cause opportunistic infections and cancers. And so if people are late diagnoses, for example, or if they've not been engaging in care for any reason, then we can unfortunately see complications of HIV and then have to manage those on a longer term basis. Top right, this is the array of HIV medications we have. So again, if people have, for whatever reason, not been taking their medication as prescribed, then they can develop resistance. So then we have to really think about how we give them the combination that will best work for them. And then in my population in Croydon, the majority of our patients weren't born in the UK, so we support them mainly by signposting, but we have links with a lot of third sector organisations for immigration issues, for example. We now have a psychiatry team, HIV liaison psychiatry team, that I'm just checking that people can hear me, because I can see that Frankie said, please type yes, and nobody's typed yes yet. So I just want to double check I'm not talking to myself. If you can hear, can you just type yes in the chat box? Oh, brilliant. Thank you, Olivia. Whew. So we have an HIV liaison psychiatry team that join us for our weekly MDTs, for example, that we can refer patients to support them with any psychiatric comorbidities, which again are incredibly common in people living with HIV. So it's estimated to be about a third of patients. We look after patients throughout their pregnancy, and again, it depends which clinic you're in. So when I worked in Manchester, we had about 2,000 patients living with HIV, but the majority of them were men who have sex with men. So although there were pregnancies, there weren't loads. Whereas in Croydon, about half of our population are women. So there's a lot more pregnancies than there were in Manchester. So depending on your demographic, or depend on the kind of not issues, but the things, the people that you will see, and the problems or the diagnoses that they bring with them. And then finally, just like GUM, we do a lot of preventative work in HIV medicine. So it was estimated in one study that people diagnosed with HIV these days actually live 10 years longer than people who weren't diagnosed with HIV, because we pick up things early. So, for example, everyone over 40 has a Q risk 3 every year, which is a cardiovascular risk score. So we talk to them about smoking, we talk to them about cholesterol, we talk to them about weight management and exercise and diet. We pick up the fact that their kidneys aren't doing so well. We pick up their hypertension in their 6-monthly visits to the clinic. So again, very broad spectrum of what we deal with in the outpatient clinic. And then GUM and HIV inpatient care. So again, this depends where you're working, and some hospitals don't offer inpatient care. It depends on your population. Obviously, the hospitals with the bigger HIV populations will offer the inpatient care, or sometimes it will be centralised. But I've seen inpatients without HIV who have severe herpes, for example, who've needed suprapubic catheters and need some sexual health advice, people with sexually acquired reactive arthritis. And then on an HIV side of things, primary HIV infections. So, for example, I saw somebody with HIV meningitis, those with opportunistic infections who are either a late diagnosis or haven't been taking HIV medications. So TB is very common, cryptococcal meningitis, which I've just realised I've spelt wrong, apologies, PCP pneumonia, and then HIV-associated conditions. So, like I said, not those conditions that are caused by HIV themselves necessarily, but that are associated with HIV, and HIV can definitely contribute to those conditions developing. So cardiovascular disease, chronic kidney disease, and addiction and psychiatric diagnoses. So not just, obviously, the clinical part is a massive part of what we do, but there's lots of other aspects of the job. So quality improvement, I just wanted to give an example. So this is the team that I work with at Croydon. So it's my colleague in the middle in Cormac, and our registrar who left last year, Linda. They were, or our team, but they were leading it, were awarded the Univance Healthcare Excellent Global Award. And my colleague Ian just got back from South Korea last week to be presented with this award. So we started opt-out HIV testing in the emergency department at Croydon, and it decreased mortality from 23% to 0% over an 18-month period. Length of stay went from 23 days to 4 days. It's just been an absolutely fantastic intervention. We've picked up lots of new diagnoses. I think we're at 35 new diagnoses now over a 2-year period. And these are people who don't attend the sexual health department, so would be missed in the screening that we would usually do. In terms of quality improvement, obviously there's loads of things. So in sexual health, I developed a traffic light tool for breastfeeding, so that staff knew which medications were safe for breastfeeding and which weren't. And spoiler alert, most of them are safe, which is great news for the patients. We have introduced testing for latent TB in our HIV patients. I've rewritten our pregnancy in HIV and pregnancy with syphilis guidelines, and we work much more closely now as an MDT than we did. So there's anything that takes your fancy in terms of quality improvement. And I think it's difficult when you're a junior, because you might see something that you think needs to improve, but you don't have the time perhaps to focus on it, or you're so busy with all the other things that you have to get done, like exams and very onerous on-call rotas, etc. But what I really love about now being a consultant is that actually I can see something that doesn't work as well as it should and say, right, I'm going to change that, I'm going to make that better. So in terms of education, because it's a mainly outpatient specialty. So although we have inpatients at Croydon, we normally have anything between sort of 1 and 5 inpatients. So this isn't sort of an inpatient heavy job. There's lots of time to incorporate other aspects into your job plan. So as an example, one of the things that I do is I'm an educational supervisor for the registrar in sexual health, but also for an F1 who doesn't even work in sexual health, but I'm their educational supervisor. The top right picture, that's the Worshipful Society of Apothecaries, who run our diploma in HIV and diploma in GU medicine exams. So there's opportunities to be an examiner. In the bottom left, supporting excellence in medical education, NACT is the organisation for healthcare educators. So I'm the Deputy Director of Medical Education at our trust. There's also opportunities within the medical school. So St George's is the medical school along with King's that sends students to Croydon, but wherever you are in the country, there'll be links with medical schools. Whether you're a teaching hospital or district general hospital, most hospitals will have medical students in a higher or lower proportion. So one of the things I really enjoy about my job is it's very varied. I think if I just did clinical medicine all day, I'd get quite bored, but having the other aspects to my job I find really rewarding and interesting, and I'm constantly learning. So management and leadership, again, just loads of opportunities to get involved in things. So clinically, you can be the clinical director of the unit if you want to. You can rise up the echelons of the hospital. If one of our sexual health consultants was deputy medical director until she retired. In terms of the GMC, there's roles that you can do in terms of medical school assessments and visits. One of my colleagues is a medical examiner, so all deaths now in the hospital have to be run by the medical examiner, and they examine the case, make sure there's nothing that needs looking at further. So the sessional work very much lends itself to these additional roles if you're interested. That said, if you want to fill your day with clinical medicine, then that's absolutely fine too. And research as well. So I did a Google for PhD programs in HIV, and the top one was what came up. So if you're very bench research focused, then here you go. Peptide hydrogels as a long-acting multi-purpose drug delivery platform for combined contraception and HIV prevention. Sounds very interesting, though not up my street. And in HIV medicine, with all the drugs, there's an abundance of drug trials that go on. And then in sexual health, there was recently, from 2016 to 2021, there was a Lustrum study, which looked at things like giving epidemiological antibiotics to people with chlamydia. So, for example, not waiting for people to test positive, but giving antibiotics in advance and seeing how effective that was at reducing infection and onward transmission. And there's about 20 HIV vaccine clinical trials ongoing. And this isn't even including all the qualitative research that you can do. So looking at how people deal with their diagnosis, how HIV is perceived by healthcare professionals, for example, how patients deal with a diagnosis of herpes and how healthcare professionals can support them in that. So in terms of the positives of the specialty, I think it's incredibly varied and interesting. Obviously, I would say that because it's my chosen career. I think one of the things that I was reflecting on as I was preparing this talk was how every couple of years something new comes up. So I remember going off on maternity leave, and I came back and there were about 5 new HIV drugs that I didn't know, and had to keep looking them up and try to remember what they were. And that was just being off for a year. PrEP, as I mentioned before, was a new intervention which has been incredibly successful, and we're now seeing the first couple of years of decreased HIV diagnoses, which we've never seen before. And we think that is real decrease rather than decreased testing, because the testing has stayed steady, but the diagnosis rate has gone down. And then more recently, you've probably seen in the news monkeypox. So sexual health are taking a front and center role with monkeypox, because a lot of the patients, in fact, the majority of the patients being diagnosed at the moment are men who have sex with men. And so they're being seen in the sexual health clinic with coexistent infections as well, like chlamydia, gonorrhea, syphilis, etc. I can't believe I've got this far and I've not mentioned syphilis yet. Syphilis is brilliant. I love the fact that I can cure patients. So it's really nice when a patient comes in and they're absolutely devastated when you tell them their diagnosis of whatever STI it is. And I say, don't worry, we can sort that out for you. Take these antibiotics for a week and it'll go away. Things that are not curable but treatable, like warts and herpes. Again, so much stigma surrounds these diagnoses, and patients will be sobbing in my room, and I'll be able to tell them that it's really not a big deal in terms of their health, that this is something that feels horrendous today, but in 6 months it'll be one tiny part of them, that herpes is just a cold sore but on your genitals rather than on your mouth. It's incredibly common. By the age of 80, over 90% of people will have antibodies for HSV 1 and 2, so most people will be exposed to it in their lifetimes, etc. It's really nice to have somebody leaving your clinic much happier than when they came in. And I feel like in other specialties, particularly where you're giving really bad news on a regular basis, you have to have that mental resilience to deal with the devastation that you're not causing to people's lives, but the diagnosis you've given has caused. And what I love about sexual health is really there isn't any diagnosis that I can give that's bad news, because even if it's HIV, I can say to them, look, actually, this is really great that we've found this at this point, because we can give you treatment, and within a year you're going to be living a completely normal life again. I like the fact that we care holistically for patients, and that includes prevention, mental health, preconception, pregnancy care. We see this massive demographic of patients, so men and women. We do see children in the sexual health clinic, so if they're sexually active and it's consensual, then we will see them. We see women through their childbearing years and postmenopausal as well. I like the fact that my patients don't often die. When I was choosing what specialty to do, I thought I might want to do palliative medicine, and I did an F2 placement in palliative medicine, and it nearly broke me. And I realised that actually a specialty where all my patients die, or majority of them die, isn't actually for me. And that's one of the really good things about sexual health, is that you give patients a normal life with the interventions that we have. And like I've said, clinical work is easily combined with the non-clinical opportunities. What are the challenges in the specialty at the moment? So I'd say we're going through this transitional period, and I'll talk a bit more about that in a second, because new trainees in sexual health are now going to be dual accrediting in internal medicine. There's also been some transition over the past probably 10 years with the Health and Care Social Act and tendering of services. So services did move to private companies, for example. I think a lot of that storm has now been weathered, and there's more stability, and people understand that sexual health isn't necessarily a money-making enterprise. And so some companies have stopped bidding for the tenders, and it's moved more back into the NHS. It annoys me when people ask me, why would anybody want to do that? I mean, hopefully I've convinced you with my chat about why people would want to do that, because it's brilliant and it's interesting and it's varied, and I get to make a real difference to people's lives on a daily basis. It's a smaller specialty, so that means two things. One is that you are somewhat limited in terms of jobs. It's not like geriatrics where there's like 8 jobs at each hospital. In smaller areas there may be 1 or 2 consultants in a hospital, but there's still plenty of jobs out there. And even rural areas need sexual health doctors, although your HIV cohort may be smaller than in Brighton, for example. And if you're somebody who needs that heroism and to save lives on a daily basis, then I'm afraid we can't offer that in the short term. But I would argue that we save a lot of lives over the longer term with our HIV diagnoses and the interventions that we can offer for people living with HIV. So I'm going to move on now to application to the specialty. I'm hoping that with everything I've talked about, I've convinced you that you want to apply. And this is how you do it. So you do your foundation training, which is 2 years, and then you apply to internal medicine training, which is now 3 years. So when you get to IMT3, you apply for your specialty training, and at that point you would apply for GUM. So you do your MRCP while you're doing IMT, and then you would apply for GUM and get a post, and then it's 4 years. And during those 4 years, you do your sexual health, HIV, and also internal medicine competencies. And after the 4 years, you would CCT with a CCT in GUM and internal medicine. And at that point, you can apply for consultant posts. So in terms of the examinations that you do during specialty training, there are 2 compulsory exams, which are the Diploma in GU Medicine and Diploma in HIV Medicine, that have a best of 5 paper and an OSCE. And then there are some optional assessments now. So one of those is Diploma of the Faculty of Sexual and Reproductive Healthcare. So that's more about contraception, and then Letters of Competence in intrauterine devices and subdermal implants. So that's being able to do coils and implants as well. So as an example, like in my job, I don't do contraception in a major way. So like I said, I can explain to you about an implant and the side effects and the failure rate, etc. But I don't have an implant clinic where I put them in, whereas some of my colleagues, particularly in smaller services, they will do an implant clinic. One of the things that's worth being aware of is generally speaking, it's very expensive to use a consultant to put in implants and coils when you can employ a band 6 nurse, for example, to do that, at probably a third of the price. So generally speaking, it will be the consultant that would run a complex coil clinic, for example, so perhaps with patients with fibroids or stenosed cervical os or something along those lines. So just to explain a little bit more about how training will work, so this is all very new. And there will be some flexibility, particularly between regions, depending on how training is set up. But these are some of the options that have been suggested for people to train in GUM and internal medicine. So you might do, for example, 3 months of internal medicine, 9 months of GUM, 3 months internal medicine, 9 months of GUM, and on it goes. There's certain stipulations about you have to do at least 3 months in your final year, and that's so when you CCT, if you get a job that includes general medicine, you're ready to go. And throughout the 4 years, you need to do at least 12 months of internal medicine. But part of that internal medicine, 3 months of that can be when you're doing HIV inpatients. So actually only 9 months of it needs to be general medicine, although it would depend on the speed at which you reach your competencies. So you can see the other options here. It might be that you do 6 months of GUM and then 3 months of internal medicine, then 9 months, or a year of GUM, then 4 months of internal medicine. So it very much, there's lots of flexibility there, and it will depend on how the training program is set up in the region that you apply to. So the application process, it's national recruitment, and round 1 generally opens in November and closes in December, and that's for the sort of traditional August, September start. And then round 2 generally opens in July and closes in August, and that's for a sort of traditional February or around that time start. Round 1 tends to be the bigger round where most people apply, and round 2 is sort of more of a backup round, and round 2 doesn't open every year, so it depends on how many posts are still available. So if you want to apply for GUM, in the future, please don't presume that round 2 will definitely run, because there is a possibility that it may not. So the application criteria, there are 10 categories, and I've put the link for where you can find these on the JRC PTB website. But in brief, they are additional undergraduate degrees, postgraduate degrees and qualifications, additional achievements, MRCP, presentations and posters, publications, teaching experience, training and teaching, quality improvement, and leadership and management. And each category, you self-assign yourself a score. And for example, with I'm trying to think, MRCP, so the highest score would be if you've got part 1, part 2 and paces. The lower score would be if you had part 1 and part 2, and then the lowest score, a lower score again would be if you just had part 1, and then the lowest score would be if you didn't have any of your MRCP, for example. So what I would really recommend doing in whatever specialty that you want to apply for is having a look at what the application criteria are now, even if you're a medical student or a foundation doctor, and just seeing what it is, what are they looking for. And then it means that you can tailor the extracurricular activities, your quality improvement activities, etc., that you do to that application, because there's no point doing a quality improvement project for something that you're not really interested in when you might have been doing one in a specialty that you are interested in that can then also count towards your application. So the interview at the moment, and this does and can change on an annual basis. So for example, with the pandemic, it went from panel interviews to just having 2 interviewers that ask you all the questions. So at the moment, there are 4 questions. So the first one assesses your clinical scenario and your communication skills. The second question looks at your suitability to be a medical registrar. The third question is an ethical scenario. And the fourth question is suitability and commitment to the specialty. And then they calculate a raw interview score. And they add that with your application score to give your total score. And there's certain criteria, like you can't score lower than a certain amount in more than one question. But if you reach a minimum score, then you are appointable at that level. So I'm just showing you this before I show you about building a portfolio. So the gum competition ratios, hopefully for you guys, are good news. So I'm sorry the text is a bit small, but this is 1 here. So 1 means that there is 1 applicant for every post available. So what you can see here is that, so this is 2015. So 2015, there's 1.2 applicants for every post. So the odds were pretty good. And then in 2016, that went down to 1. 2017, it went up again. But since 2017, every year, the number of applicants has been lower than the number of posts available. So if you want to do sexual health, your chances are exceedingly good at getting in at the moment. Now, obviously, I'm hoping that improves, because I want everyone to realise what a wonderful specialty it is. When I applied in 2013, I couldn't find any figures for before 2015, but in 2013, it was incredibly competitive. But I think with the Health and Social Care Act, people got a bit worried about what was going to be happening, were jobs going to be available, were consultant jobs going to be available. I can tell you now, there are lots of consultant jobs, and there are lots of people coming up for retirement in the next 10 years. So we are very keen to recruit new enthusiastic registrars to fill those consultant posts. And this is just the figures. So you can see in 2015, there were 35 applications for 29 posts. And, you know, there's been some pretty bad years. So duplicated. So 2019 was a particularly bad year where there was only 20 applicants, but there were 46 posts. So, you know, half of the post went unfilled, but then it has improved somewhat, and hopefully the trajectory we are seeing, I mean, from my perspective, is improving. From your perspective, you might like it to stay quite a good competition ratio from your perspective. So building your portfolio. So if you're interested in sexual health, there's loads that you can do. So I'll just briefly talk about what I did. And the things that I did, they weren't really, I didn't know that I wanted to do sexual health as a career. I knew that I found it interesting. And so as a medical student, I trained to be a peer educator. So I used to go to high schools in Salford in Manchester and do peer education, sex education for year 9 students, which I think has stood me in good stead for the patients that I see these days. I also did my elective in Tanzania. So that wasn't planned because it had a high prevalence of HIV. There were other reasons that I went there, but then I ended up sitting in a lot of HIV clinics and finding it really fascinating. I also used to be involved in girl guiding, and through them I did a project on sexual health and HIV. I went to talks that the university was putting on, etc. So I had quite a lot of experience as an undergraduate, and then as an F2 I did an obs and gynae post. I still didn't know what I was going to apply for at that point, and I was in the termination clinic and we were doing sexual health screening and also talking about ongoing contraception post-termination, and I just found that really interesting, but I knew that I wasn't a surgeon and I didn't want to be an obstetrician, and so sexual health seemed like a really good specialty for me to go into. So that was sort of my experience. And then I did shadowing as well, because I never had the opportunity to do a sexual health job before I applied for it. So I sat in, I think, on 3 clinics, but I knew that I wanted to do it, and I wasn't wrong. So think about, if you're a medical student, think about where you might want to go on your elective. Do you want to go to a country that's got a high prevalence of HIV? Maybe you don't want it to be an HIV focus, but if you go to a country that's got or not even a country, if you want to stay in the UK, you might choose to go to a London HIV clinic, or Brighton, or Manchester, or Leeds, Birmingham, somewhere with high prevalence of HIV. And if you go to a country where the HIV prevalence is high, then even if you're not doing an HIV job per se, you'll find that HIV touches all of the specialties, because you're thinking about drug interactions and you're thinking about how HIV might be contributing to the diagnoses that you're seeing. In terms of volunteering, so I've just put a few examples here. So I'm volunteering at Croydon Pride next weekend. We're going to be giving out condoms. We're going to be doing point of care HIV tests, so people get their results there. And then George House Trust is a charity in Manchester that I volunteered with for a short time, and they support people living with HIV. The Food Chain is a charity in London that supports people with HIV living in food poverty. It helps with cooking classes and also food parcels and food and financial management. So they look for volunteers. National AIDS Trust looks for volunteers. Positive East is a charity in East London. So wherever you live, there'll be charities, organisations that are looking for volunteers to support them. One of my colleagues, so if you don't live in an area where HIV is particularly prevalent, then there may not be as many opportunities like that. But for example, one of my colleagues, he volunteered with the Sex Workers Outreach Centre. So he'd go there every week and would, make people cups of tea, have a chat with them. And actually, he never told them that he was a doctor because he didn't want to be providing medical advice. He was there as a supporter. In terms of projects, like I mentioned earlier, be smart. So think about how, if you need to do an audit or quality improvement project, or you're interested in research, think about how it's going to complement your career goals. So don't just take any old project. Think about how you might be able to incorporate what you're interested in with ticking a box on a form, because unfortunately you have to play the game a little bit to get where you want to be. So I'll talk about this in a second, but you, as a medical student or a junior doctor, you can be on guidelines writing group for chlamydia, for example, or PrEP, or there's lots of special interest groups via some of the national associations that would love to have non-specialists on the group to provide them with a bit more balance and ideas outside the specialty, because we all know that when you've worked somewhere for a long time, you can get a bit blinkered and not be so innovative anymore. Shadowing really helps. Taster weeks if you're in foundation, and there's also these national gum taster days. So I did that many moons ago, 10 years ago now, which was a day of talks and lectures in London, and then a day in a clinic in London. So I went to a clinic in East London, and I was living in Manchester at the time, so that's open to anybody. And clinical fellowships as well. So we employ 2 clinical fellows a year who work in our sexual health department for a year. They look after the HIV inpatients. They do gum clinics downstairs, so they get a great foundation in the job and learning what it is. And hopefully we convince them that they want to be sexual health doctors. So national associations, there's 2 main ones. So the British Association for Sexual Health and HIV, which is free for students to join. So please do join if you're interested in sexual health and you're a student. And for doctors in training, so this is at any stage of training, including registrars, it's £95 a year, and that includes both sexual health journals as well. And then the British HIV Association costs £40 a year for a medical student to join, and is £95 a year for a non-consultant. And what I would say, you don't necessarily need to join both of those, but if you are interested in the specialty, then I would recommend joining one, and then that opens up your opportunities to get involved in other things. So for example, as a BASH member, you can get involved in their special interest groups. So there's one for racially minoritized communities, there's one for, they changed its name, gender, it used to be the might be gender minorities group, so it's basically for people who don't identify as straight. There's the genital dermatoses special interest group, there's the bacterial STI special interest group, there's the viral STI special interest group. So and this is the way as well that you can get involved with the writing guidelines. So BASH will send out their newsletters with the opportunities that are there and things that you can be involved in if you want to. And like I said, we love it when people who are keen and enthusiastic and perhaps have got a bit more time as well want to get involved in these things. There's also a dedicated organisation called STASH, which is the Student and Trainee Association for Sexual Health and HIV, which sits under BASH, and that was formed only last year, but they want to highlight the specialty, because I think a lot of us feel that we're a bit too hidden. They always put the building sort of in some faraway part of the hospital, so we don't necessarily get to liaise with colleagues as much as we like to, and we're not a big specialty like gastro or geriatrics or respiratory that I don't think you can avoid during your training. So I'd really encourage you to engage with STASH and the BASH trainees as well. So I've put there's an email address, trainees@bash.org, that you can contact. And if you go to the Twitter page and follow them, there's more information on there. There's these 2 opportunities that were on their Twitter page. So they're looking for 2 STASH committee members, an ambassador coordinator and a secretary. And both the deadlines for applying for those roles closes on the 13th of July, which is in 2 days' time. So if you are interested, please do drop an application. So sorry, this text is very small, but it's basically it's saying the steering committee aims to provide educational opportunities relating to sexual health and HIV medicine, including revision sessions, specialty workshops, support career development through mentoring, careers fairs, and creating a forum for networking, promote and facilitate opportunities for collaborative audits, research and quality improvement led by medical students and trainee doctors across the UK, and facilitate opportunities for presentation of student projects at local and national conferences. So the ambassador coordinator, the role involves recruitment and management of STASH local ambassadors, sharing updates, quarterly meetings, sharing student perspective to the steering group, promotion of STASH activities and active participation in STASH events. And then the secretary role involves producing minutes of the steering committee, maintaining organisation of the Gmail, Google Drive and Slack, promotion of stash activities, and active participation in stash events. So if you are interested, then again, this would be a wonderful portfolio building exercise, but also a great way of meeting people, getting to know more about the specialty. So I've just added a few references and useful links there, but if there's anything that you want and you can't find, just drop me an email and I'm very happy to forward it on to you. Just wanted to draw to a close really and say thank you so much for your attention. I wanted to leave it on this slide because I think if you are interested in specialty, these are going to be your first go-to people. But please do get in touch with me if there's anything that you want to know, or I can signpost you to the right people. So yeah, looking forward to you all applying in the next few years. Frankie, if you're still having trouble with the internet, feel free to write in the chat and I'll answer any questions there. Yeah, I can't hear you, but I can see the chat fine, so. So question is being a med reg the only route to get in? So now, yes. So GUM has joined the Group 1 specialties along with palliative care and neurology, I think. So to do GUM training, you have to do IMT, and there is no option to do GUM training without doing IMT competencies, so internal medicine competencies during your training. That doesn't mean that when you CCT you have to do internal medicine. It depends what jobs are available. So at the moment, for example, you won't find any jobs that have got internal medicine with them because none of the trainees who are CCTing have got internal medicine competencies as well. But I think as people are coming out with more internal medicine competencies, that those jobs will grow. But they're, it's hard to predict the future, but there may well be pure GUM posts that don't have internal medicine in them as well, depending on what the trust or the organisation needs. I think particularly those services at the moment that are run by non-NHS providers who don't provide inpatient care, for example, they're not going to be looking for somebody with a massive interest in internal medicine because they don't provide those services. So I think there's always going to be opportunities for both, but I think as the number of people with internal medicine dual accreditation increases, the consultant posts will start to reflect that more. So work-life balance, I'd say it's really, really good. So I'm not ashamed to say that one of the reasons I chose GUM was because I wanted a good work-life balance. I was a bit older when I came to medicine and I didn't want to be in my 40s and still doing nights and weekends. As a registrar, your sexual, it depends where you work, but I worked in really big centres. So, routinely had sort of 2,000, 2,500 patients living with HIV. So we would generally do non-resident on-calls. So we'd have the phone and people would ring us overnight. And that might be with queries about whether to give post-exposure prophylaxis, or it might be that a new patient had come in with late-stage HIV, for example, and the team wanted some advice on what to do, what investigations to do, that kind of thing. There are lots of lots of departments at the moment where there isn't an on-call commitment because there isn't the sort of need for that 24/7 advice. I'm just trying to think. So yeah, in the 4 years, I worked in 4 different departments, and 2 of them didn't have an on-call commitment, and 2 of them did. But my on-call commitments were switched to sort of more out-of-hours commitments, so evening clinics and things. So I still got banding, which was fantastic. As a consultant now, so we have nearly 1,000 patients living with HIV. We do look after inpatients, so I do at the moment a 1 in 3 non-resident on-call rota with 2 consultant colleagues, but it's very manageable, and it is unusual for me to get called in the night. And we do get called at weekends sometimes, but I don't ever have to go in. All the advice I give is over the phone, so it doesn't stop me from doing nice things at the weekend or in the evening if I want to. Obviously, if I'm on call, I can't drink, but that's the only issue really. So yeah, it's brilliant work-life balance. I think with sessional nature, the fact that it's mainly outpatients really lends itself to part-time working as well, flexible working. A lot of my colleagues in other departments work from home, particularly post-pandemic. So yeah, that's, I'd say, one of its, probably I should have mentioned that earlier, shouldn't I? But that's one of its main draws, I think, is the work-life balance that you get. And that's in training as well. So I think a lot of specialties, you get the work-life balance once you're a consultant, but not in training. And actually in training is when you're trying to live your life, you're buying a house, you're having kids, etc. So yeah. What do I enjoy the most, and what have I found the most challenging? The most challenging bit of training was the first 2 years. I was the only registrar. No, that's not quite true. So in my first year, I actually worked in the infectious diseases department. And although there were infectious diseases registrars, there weren't any other gum registrars. So that was a bit lonely in terms of just somebody understanding what the challenges of my job were, having somebody to chat to about what I needed for ARCP, that peer support. And similarly, in my second year as a reg, I was the only reg in that department. I was the only reg at all in that department. So, there's pros and cons to that. The pros are that you get undivided attention because you're the only trainee, but the cons are that you don't get that support from your colleagues. So that was quite challenging. Challenges now as a consultant, I think just not enough hours in the day to do all the things that I want to do. So I've done the typical, I've been a consultant for 3 years now, so I'm fairly new still, but I've done the typical thing of taking on far too much and then not having enough time to do it all. So, and that's because it's also interesting. So I'm sitting on the National Chlamydia Guidelines Writing Group, and I've become the external assessor for the Diploma in HIV Medicine, and I'm an appraiser, I'm an educational supervisor, I'm now our Trust Deputy Director for Medical Education. I've probably forgotten things. Oh yeah, I have an outside role in industry, so I work as a consultant for another organisation, sort of using my sexual health and HIV knowledge. So yeah, I just need more time to do all the things that I'm interested in, or need to learn to say no. That's the other one. And what have I enjoyed the most? I can genuinely say that I really love my job. It's quite normal for me to have a laugh with the patients and to share real moments of connection with them when I understand what they're going through. I understand why they're upset, or what's happened in their relationship that's led them to be in that seat. I love the fact that I can put people at their ease, people who've never been to the clinic before. I mean, last week I saw a 76-year-old who'd never been to the clinic, and he was really nervous about coming, and same could be said for a 20-something-year-old when they've not been before, that you can put them at their ease and you send them out of the clinic happier than when they came in. I think that feels like it's quite unusual for a medical job, and also making such a massive difference to people living with HIV as well, and being their advocate. And supporting them to register with a GP practice when they've been denied registration because they don't have their passport, for example. So yeah, I just find it a really rewarding role, and I really enjoy the patient interactions and the job that I get paid to do. I feel very lucky that somebody pays me to do what I do all day. Any other questions in the last 4 minutes? No, last one. Make it a good one. Keeping me in suspense. Okay, when did I start working on my portfolio? So, I mean, accidentally, sorry, I just need to move my legs and they're cramping. Accidentally, I started working on it as an undergraduate. But that was mainly just because I was doing things that I was interested in, and I didn't know at that point that I wanted to do sexual health. I think I'm one of those sort of geeky, slightly neurotic individuals that started looking at the core medical training as it was application in F1 and just looking at what it wanted me to do, so I could, like I said, be smart and tailor what I was doing to the application. In terms of finding the time, well, it's stuff that you've got to do anyway. So in foundation, for example, you've got to do a quality improvement project. In core medical training, you've got to show that you've got some interest, I think, in research or whatever, whether that's going to journal club and critically appraising a paper. Choose a paper that's related to the specialty that you're interested in. So I'd say you can spend loads of time doing additional things, but actually if you choose the right things, then you can tie it into whatever you've got to do anyway for your training, whether that's undergraduate or postgraduate. So for example, going on an elective to somewhere that's relevant to the specialty that you're interested in just makes sense, whether that's in the UK or abroad, because then I could write in my ST3 application, as a final year medical student, I went to Tanzania and sat in on the HIV clinics there, so showing that I'd got an interest and had an understanding of the specialty. And then finally, any tips for medical students for opportunities to look out for? So join Stash, get in touch with them, email them, say that you're keen, and they will fall over backwards to give you opportunities and let you know what to do. Also, get in touch with your local sexual health clinic and tell them, just Google the sexual health clinic and find out who the clinical lead is or one of the doctors there, and find them on nhs.net and send them an email and just say, I'm interested in sexual health, like, is there anything that I can do? Have you got any audits that you need help with, or is there anything else? So yeah, I mean, if somebody got in touch with me and asked to do some stuff, I'd be delighted. If anybody wants to help me with a UTI in sexual health audit, you're very welcome. So Frankie's just saying, please fill out the feedback form. You'll get a certificate of attendance, which will show your interest in the future. There you go. Boom. One portfolio building activity done. So thanks, everyone. I hope you enjoyed it. I hope it was helpful. And yeah, get in touch with me, get in touch with Stash, and apply for GUM because it's great.